Hello, I'm hematologist-oncologist Dr. Tony Talebi. Today we're going to discuss the management of stage 4 soft tissue sarcomas. I have the pleasure of being with Dr. Jonathan Trent, professor of medicine at the University of Miami and co-director of the Sarcoma Site Disease Group. Thank you for being here.
Thank you.
All right, Dr. Trent, let's assume a patient has been diagnosed with sarcoma, but now the imaging shows that there are other spots in the body that the cancer has presumably spread. What happens next for that patient?
So at this point in time, I would meet with the patient and explain to them that they now have a situation called metastatic sarcoma. So metastatic sarcoma means the sarcoma has spread from the primary site and is now involving lung, liver, bone, other sites, and is largely not thought to be curable. Although if you look at larger retrospective series with most types of sarcomas, there are a fraction of patients that with metastatic disease that can be cured with chemotherapy alone or chemotherapy often in combination with selected surgeries and radiation therapy. But the emphasis is that it's very difficult disease to cure. The probability of cure is very low, and the goal of chemotherapy is largely palliative in order to shrink the tumors, in order to hopefully buy the patient more time with good quality of life.
So as you know, for patients it's always more important whether they can be cured. What is your threshold cutoff? How many sites of spread is your threshold in terms of surgically removing everything or not?
So typically the way I approach it when a patient has a newly diagnosed metastatic sarcoma is to offer them very aggressive treatment with chemotherapy. Very aggressive treatment with chemotherapy may begin and then have 2 cycles, repeat imaging. If we're shrinking the tumors, then I continue with chemotherapy as long as the patient's tolerating it to shrink the tumors as much as possible. At that point in time, I visit with a surgeon or a radiation therapist or may present the patient at our multidisciplinary conference with the question of what type of surgery would be required to remove all of the patient's disease. The patient may have only one nodule in the lung. If that one nodule is in a location in which it can be resected, then it would make sense at that point to at least consider surgical resection of that site of tumor, and then often give a couple more cycles of chemotherapy after surgery, and then follow the patient every 3 months with repeat imaging.
So let's say if cure is not possible, if that's completely out of the question, do you still remove the primary tumor surgically? Does that make sense or no?
It does make sense in the setting where a primary tumor might cause patient symptoms. So if the primary tumor is in the extremity or in the retroperitoneum or in the peritoneal cavity and is compressing a nerve and causing pain or potentially causing obstruction, then resecting that primary tumor does make sense in order to avoid morbidity in the future.
So that would still fall under the realm of palliation?
Mm-hmm. Absolutely.
Now, what chemotherapies would you use?
So for the majority of soft tissue sarcomas, the most active chemotherapies are adriamycin and ifosfamide. There are situations where other chemotherapies are considered for patients in the initial metastatic setting. So frontline therapy, for instance, for non-uterine leiomyosarcoma, many of us sarcoma medical oncologists are using adriamycin and dacarbazine because the data with ifosfamide that's been reported at meetings is not very good for non-uterine tumors. Uterine leiomyosarcomas do seem to be ifosfamide sensitive. So that would be the mainstay of therapy in those 2 types of situations. Now there's other situations such as GI stromal tumor that is completely resistant to chemotherapy. Those patients should be treated with Gleevec as their initial therapy. Chemotherapy in GI stromal tumor results in a median overall survival of only 9 months. Gleevec, on the other hand, leads to an overall survival of about 5 years. So Gleevec is certainly frontline therapy for GI stromal tumor. Dermatofibrosarcoma also does not respond to chemotherapy, and those patients can be also treated with Gleevec. Desmoid tumors are a little more difficult of a challenge because they can respond to chemotherapy, but also to targeted therapy such as Gleevec, or more recently Nexivar has been used in some patients. Also to tamoxifen, also to anti-inflammatories even, such as Celebrex and Sulindac. So there's a number of therapies for desmoid tumor that one could employ in the frontline setting for a locally advanced disease that can't be resected, and one has to pick which one to use based on the anatomic location and how quickly you need a response. Now for the angiosarcomas, I usually use adriamycin and ifosfamide frontline, although in the appropriate patient you could use a taxane or even Gemzar in the front line. So it kind of depends on how quickly you need a response, what type of response you need, what's the anatomic location, and most importantly, what is the histology. Now you also have to remember that there are a subset of soft tissue sarcomas that don't respond to any chemotherapy. Alveolar soft part sarcoma, as well as clear cell sarcoma. They don't respond to chemotherapy at all. And so they go on clinical trials where there's a number of emerging therapies. For instance, there was a study using a medication called Votrient or pazopanib, and in that study a number of patients with alveolar soft part sarcoma had great responses, great regression of disease, and many are still doing well today. So that additional studies with that drug are ongoing, but it is available for other diseases, so we use it a lot in sarcoma. And clear cell sarcomas are resistant to chemotherapy, but in clinical trials there's been anecdotes of patients responding well to MET inhibitors. So the newer drug crizotinib that's been approved for ALK-positive lung cancer is also a MET inhibitor. So it would be a frontline option for a patient with metastatic clear cell sarcoma because we know chemotherapy doesn't work.
Let's take the standard adriamycin-based chemotherapy regimens. What type of side effects can the patient experience?
So adriamycin ifosfamide, the typical regimen that we use here is 75 milligrams per meter squared adriamycin combined with 10 grams per meter squared ifosfamide. So this is very high dose intense chemotherapy. And there are a lot of serious side effects with it. Luckily we have a number of medications today that allow us to really ameliorate the side effects that the patient has. So common side effects with AI chemotherapy are nausea, vomiting, neutropenia, often neutropenic fever, and mucositis. And I'll just give you an example of a patient that I had with synovial sarcoma who I recommended adriamycin 75 milligrams per meter squared with ifosfamide 10 grams per meter squared, but she wanted to receive her therapy at home with her community oncologist. So she went home. Community oncologist gave her the therapy. She had neutropenic fever, she had mucositis, and she had terrible nausea and vomiting, all requiring admission to the hospital. So she came to see me after she recovered from that and was not too happy. But I reassured her that we could treat all of these side effects. So I said, hey, let's treat the nausea and vomiting with aprepitant, Emend. Let's treat the neutropenic fever with Neulasta, and let's also give you a fluoroquinolone antibiotic to try to prevent it. And let's treat the mucositis with palifermin. And so I made those recommendations. She went back home to our community oncologist. The community oncologist decided instead to reduce the Adria to 60 and reduce the ifosfamide to 8. So she had the exact same side effects. And so she came back to me and was about ready to quit and go to hospice. And I said, look, you're responding to therapy. Your tumors are shrinking. So she decided to get her chemotherapy with me, and I increased her doses back up to 75 and 10. I gave her Neulasta with a prophylactic fluoroquinolone. I gave her Aranesp as well as Neulasta, and for the mucositis I gave her palifermin. And with those measures, she finished that cycle with absolutely no side effects.
Amazing.
So, and Emend, aprepitant. So Emend, Neulasta, and palifermin are much more powerful measures than reducing the doses of chemotherapy. And that's not always important in a lot of cancers, but in sarcoma there is a dose-response relationship with chemotherapy and response to therapy, so we have to maintain adequate doses. And she sailed through chemotherapy with appropriate management of her side effects. And so I think some of the breakthroughs that we have made in oncology today, even in terms of chemotherapy, some of the even bigger breakthroughs we've made has been in the management of patient side effects.
Very true.
Yeah.
How do you handle depression in your stage 4 patients?
Depression is difficult, and depression is something that patients, when they're diagnosed with cancer, often deal with on and off. I've found that patients who have hope and patients who can focus on getting through today and getting through tomorrow deal with depression a little bit better. Chemotherapy patients have a lot of details to deal with, so they're dealing with side effects and they're dealing with all of their clinic visits and blood tests, and as long as they are focusing on what they need to do with their therapy, they actually do pretty well. Depression in patients, just patients who are on Gleevec, I think in my practice is even a bigger problem. They don't have side effects that are of the intensity of chemotherapy, but they do have side effects, and these side effects are chronic. They have the same side effects every single day, and with Gleevec and GIST, it's for the rest of their life. And so they have the same fatigue every day when they wake up, and it is a much bigger challenge for me to manage in my practice than chemotherapy patients, because chemotherapy patients will be sick from the chemotherapy for about 2 weeks, but they'll have a week where they feel great. And so there are different subsets of patients with different problems. Anytime a patient of mine has serious depression, though, I do refer them to a psychiatrist that has experience with cancer patients, because it is a special population.
How do you handle lack of sleep or lack of appetite?
So lack of sleep and appetite are two of the common side effects that we see in cancer, and lack of sleep is particularly difficult in my population when they're receiving chemotherapy. They may be in the hospital, and there's lots of things that wake them up in the night. Even if they're at home with their chemotherapy, they're often getting large doses of steroids to prevent their nausea, and steroids, of course, cause insomnia. So for lack of sleep, certainly you can work on sleep hygiene, but in cancer I don't think you get very far with that, so I generally use medications such as Ambien, and Ambien is very good, at least in my patient population, in managing their insomnia. The patients that have lack of appetite, the approach that I take, and this is probably more of a problem in the Gleevec patients, and the patients that have had GI sarcomas with large GI surgeries, than it is with the extremity tumors that are on chemotherapy. Those patients actually often gain weight and have a great appetite because of all the steroids.
Right.
But if they've had GI surgery, they may not have that appetite. They may have early satiety as well, and it's a big problem. So the two drugs that I use are either Marinol or Megace. Megace I've had some problems with in terms of DVTs and blood clots, and the type of weight patients gain tends to be fatty weight. So I typically will use Marinol in most of my patients to help with appetite, and patients tend to build more muscle and less fat, and it's very good at stimulating appetite, and it also doesn't cause DVTs. And the other benefit is that it helps with nausea. So if a patient is having nausea and loss of appetite, I found that Marinol is very, very effective. Now, patients on chemotherapy may have an aversion to food, particularly when they're nauseated. And there are some measures that can help with that. Certainly Marinol can help with that, but so can the type of food that they eat. A lot of times they have an aversion to food because it just tastes bland. And so I ask them to try foods that are more aromatic, like warm soups that are flavored, because even though they don't taste the food, they can smell it. And if the food has a lot of smell, then that gives it more flavor. And so that can help patients that have an aversion to food because they can't taste it, because they've had mucositis on their tongue or have lost their taste buds. So aromatic foods are more appealing to some patients. Now, some patients have an aversion to food because of the way it smells. And so those patients you put on colder foods that are less aromatic and more bland, and that seems to help them. So you kind of have to individualize it based on the specific reasons for the lack of appetite that the patient might have.
I see. What are your thoughts on a patient who takes natural herbal medicines concurrently with your chemotherapy?
Yeah, I discourage that in general, because with a lot of these natural herbal medicines, we don't know exactly what is in the medication. And some of these medications can be immunosuppressive, some of them can be derived from fungus or bacteria, some of them can also interact with the chemotherapy or interact with other agents. For instance, the medications Gleevec and Sutent interact very strongly with CYP3A enzymes, and in fact St. John's wort, as well as rifampin and dilantin and some of the other anti-epileptics, those drugs will induce CYP3A metabolism of Gleevec and Sutent and reduce the plasma level of the drug. So St. John's wort is something that I really ask my patients to avoid, because it will clearly decrease the level of the drug and they may lose efficacy. And this is true also for chemotherapy as well, and some of the supportive care agents that we use. So I usually ask my patients not to take natural supplements while they're on chemotherapy. When we're done with chemotherapy and they're taking a hiatus from chemotherapy, it would be an option.
I see. There's a whole revolution going on in oncology with molecularly targeted treatment. Would you please comment on that and some of the different medicines you use?
Yeah, so sarcoma is a collection, largely, if you're all-inclusive, of about 200 different tumors. The common ones we see are about 50 different types. And so those 50 different types, if you look at them, about half of them are caused by specific genetic events. The other half are more similar to carcinomas, where there may be 10 or 20 different oncogenes that are mutated that lead to that type of cancer. For instance, osteosarcoma, pleomorphic fibrosarcoma, or MFH. Those tumors are caused by multiple bizarre genetic events. But then the other half, like Ewing sarcoma, like GI stromal tumor, clear cell sarcoma, myxoid liposarcoma, dedifferentiated liposarcoma, these are all caused by specific genetic events, whether it's a point mutation in the setting of GI stromal tumor, where there is a point mutation or a small deletion in the KIT gene that activates the kinase that causes the cancer. It could also be gene amplification in the setting of MDM2 and dedifferentiated liposarcoma. It can also be translocations that we see, for instance, in myxoid liposarcoma, Ewing sarcoma, rhabdomyosarcoma. Then there are some other ones like dermatofibrosarcoma that has translocation of the collagen promoter to the PDGF ligand. There's another one called pigmented villonodular synovitis, and that's a translocation that involves a different collagen promoter that is driving a CSF1 ligand. And what these result in is rapid proliferation and growth of the tumor. The tumors then stop dying, start invading tissue, and may even metastasize. And this whole process is initiated by this initial genetic event. So the tumors become dependent on this initial genetic event because it provides such a powerful force for tumor cell growth and tumor spreading. So even though it's a powerful event for the tumor, for us it's also an Achilles heel, because now, as you mentioned, with these targeted therapies, we can attack that gene that is responsible for the majority of the tumor phenotype. So for instance, now with GI stromal tumor that has a mutated KIT gene, we can use Gleevec and Sutent to not only stop the tumor cells from dividing, but actively kill the tumor cells. And now patients are living with metastatic disease for many years. I have several patients with metastatic GIST on Gleevec for 12, 13 years that are doing great. And they have a great life. Same is true for dermatofibrosarcoma that we can treat with Gleevec as well due to the PDGF receptor. Same is true for pigmented villonodular synovitis that has CSF1 receptor that can be inhibited by Sutent very well. There's also a type of sarcoma called giant cell tumor of bone. And giant cell tumor of bone is caused by a paracrine loop involving rank and rank ligand. Well, rank is a receptor and rank ligand is a ligand, and this results in a tumor growth with some normal cells and some tumor cells in the tumor mass. And this paracrine loop can be cut off and inhibited by a inhibitor known as denosumab or Xgeva. And it's very active in giant cell tumor of bone in perhaps 80% of patients as a targeted therapy. So there's a number of other examples, such as
how about the mTOR inhibitors?
Yeah, so there's another example such as the mTOR inhibitors, and in this situation there are a number of tumors that are caused, a number of sarcomas that are specifically caused by activation of the PI3 kinase AKT mTOR pathway. One example is a collection of tumors called PEComa, or perivascular epithelial cell sarcoma. And the PEComas occur in families with tuberous sclerosis, but also occur sporadically. But they all have activation of this pathway as the initiating event. And so in PEComas, I've had several patients that I've treated with mTOR inhibitors that have resulted in great responses to therapy. And this has also been published in the literature. There's another type of sarcoma called myxoid liposarcoma, and as it turns out, about 20% of myxoid liposarcomas have activating mutations in PI3 kinase or AKT, or inactivation of PTEN, resulting in activation of mTOR pathway. And I've treated a couple of patients with refractory myxoid liposarcoma with mTOR inhibitor, and they have also responded to therapy. And there was a larger trial now that's been done looking at not just specific sarcomas, but all soft tissue sarcomas treated with chemotherapy to maximum response. The patients that had complete response, partial response, or stable disease were then randomized to either a placebo or an mTOR inhibitor called ridaforolimus. And this is called the SUCCEED trial. And so, as per the name would suggest, the trial did provide a progression-free survival benefit for patients that were randomized to the mTOR inhibitor after response or benefit from chemotherapy. There was also a small overall survival benefit that was observed in the study.
I see. How do you know if your treatment is working?
So in general, the best way in the metastatic setting to determine whether the treatment is effective is radiographically. There are some situations where we use physical examination, such as angiosarcoma of the scalp or of the skin. But largely it's radiographic imaging in terms of a CT scan or an MRI, occasionally functional imaging such as a PET-CT. And the way I do it is I do my imaging, and then I initiate the patient on therapy as quickly as I can, as soon as I can after the imaging. Treat the patient often for 6 to 8 weeks, sometimes 12 weeks, and then repeat the radiographic imaging at the end of that treatment period. And then one can compare the tumors before and after therapy in terms of size, in terms of contrast enhancement, and also in terms of functional imaging, for instance, glucose metabolism in a PET scan. So all of those are reasonable approaches in determine whether or not a patient is responding to therapy. It may not always be a decrease in size. One can see decrease in contrast enhancement or decrease in PET avidity that signifies a response to therapy.
Have you ever been presented with a situation where the family does not wish for you to discuss the diagnosis or prognosis with the patient? How do you handle that?
That is a very rare situation, and it's only happened to me once, and I ended up meeting with the family, meeting with the appropriate people within the hospital, and really let them know that it was in the patient's best interest and that we couldn't really deliver adequate medical therapy unless the patient knew that they had cancer and that they were being treated for cancer. So I think that that's definitely a requirement in any type of treatment, is to involve the patient and engage the patient so that that patient can get the best possible care. It's pretty rare, but it does happen.
Please explain what a clinical trial is and whether you recommend patients to enter clinical trials with stage 4 sarcoma.
So clinical trial is an experimental therapy. There's different varieties of clinical trials. And so a clinical trial for a patient could be a already approved therapy that's effective for the patient, that's being administered to further evaluate radiographic responses. So a clinical trial can match up with standard of care. There's certainly some instances where additional information on radiographic imaging is, or even biopsy is what the clinical trial is about, and meanwhile the patient is receiving standard of care therapy. So in that situation, it's perfectly reasonable and acceptable to participate in that type of clinical trial. The other type of clinical trial might be at the patient, after the patient has failed, after all standard therapies have not worked for that patient. So the patient was treated with, for instance, with sarcoma with adriamycin and ifosfamide, and that chemotherapy didn't work and the tumor grew. The patient's treated with gemcitabine taxotere, that didn't work either. And then the patient might participate in a clinical trial, for instance, a drug like trabectedin that has promise in soft tissue sarcomas would be highly reasonable in that situation also.
When would you refer your patient with stage 4 sarcoma to hospice? When do you think is the appropriate time?
That's another very, very difficult question, and there's not a definite time that occurs. It has to do with the physical condition of the patient. It has to do with what treatments, if any, are available for the patient. It has to do with the patient's expectations and the family's expectations and their wishes. And so all of these things fit together, and if the patient is at a point where they don't want any more treatment, then hospice is definitely a reasonable approach. When a patient is receiving, with metastatic sarcoma, is receiving chemotherapy, they're often spending days in the hospital, they're coming to and from clinic, they're getting laboratory testing every other day. It basically encompasses all of their time. And if the therapy is not really working very well, and the patient would rather refocus their life on spending as much time as possible with their friends and family and spending less time at the hospital, less time at the laboratory, then that's a very appropriate time to consider hospice. But again, it really comes down to an individual patient, their specific circumstances, and a discussion with their physician.
How do you give your patients with stage 4 sarcoma, which potentially is not curable, hope?
That's again a difficult situation to be in when an individual patient is diagnosed with stage 4 cancer. The odds are very high that they're going to die of that cancer. When I meet with my patients, I let them know that stage 4 sarcoma is largely not curable. Stage 4 sarcoma is a situation where the odds, the percentage is probably 90 or 95% that the individual is going to succumb to their cancer and eventually die from this disease. And that's just the way that the disease has been studied over time, and that's the outcome for most metastatic sarcomas. The converse is that perhaps 5 to 10% of patients with metastatic sarcoma can survive this illness. And the odds are not good, but the odds are certainly there. And so that, I think, gives a lot of patients hope. When we use chemotherapy and we use it appropriately and the patient gets a good response and regression of the tumors, I think that gives patients a lot of hope, because they've been putting up with side effects, they've been dealing with pain from the tumor. You give them chemotherapy and the pain improves. You give them chemotherapy and they can see the tumors regressing on the CT scans or MRI. And I think that gives patients a lot of hope. They still understand the probabilities and the likelihood that they're not going to survive, but we're clearly in many situations buying time, and there is clearly a small subset of patients that can survive.
Great, thank you so much.
Thank you.
Thank you for watching. We hope this has been educational.